Nadine Cole, from the Veterans Administration Hospital. She comes to us as a clinical psychologist, a PhD in clinical psychology from Florida Theological Seminary in Pasadena. Licensed as a psychologist both in Arizona and in California. And working with the treatment of trauma survivors, particularly looking at social skills training, stress management, has been in the past involved in PTSD treatments, was director of the unit down here at our VA, and also was a staff psychologist at another VA in Los Angeles doing PTSD work. Currently is the coordinator of the military sexual trauma unit program, and is also then the director of psychology training for military trauma stuff here at our VA downstairs. She's going to be talking to us today about military sexual trauma, a topic that, of course, becomes more and more relevant as we get into having mixed services. It's a very interesting thing. I don't know if you can get to this on transgender people. You see this in the New York Times this week, and what happens there. So a lot of really interesting things. And she has nothing to disclose. She has never in her life done anything bad. Or at least she doesn't have any funny relationships with drug companies. Right.
Thank you for that introduction.
You know, she didn't have any adjective in front of introduction.
I thought I would kind of give you an overview of what we're going to cover in the slides. We're going to look at the mandates that the VA has for treatment of military sexual trauma, look at the definition of what does that mean, and then look at some of the prevalence rates, ending up with treatment that's specifically happening here at this VA. So with that, we'll get started. So kind of as background to this, the VA is legally mandated to address military sexual trauma and has resources at each VA as well as vet centers to help survivors. There is a significant number of men, or women and men, that report having experienced military sexual trauma. And that's important because military sexual trauma is associated with a host of negative mental health and physical health outcomes. So kind of one of the things at the bottom to think about is there are a variety of traumatic experiences that we kind of expect to be part of military because it is part of the mission of the military. So for example, we know that we have soldiers who go into combat. And so being exposed to trauma is an inherent part of that mission. But military sexual trauma is not part of the mission of the VA. So it's kind of an additional thing that our veterans go through. So what is military sexual trauma? This is a VA term. It doesn't really exist anywhere else outside of the VA and the Department of Defense. And it is the term that is used for sexual assault or sexual harassment that occurred during military service. There is a definition in the public law, and I've included that on the slide here. And I want to move on to a little bit more. So it basically is any sexual activity in which someone is involved against his or her will. There's a variety of ways that that comes out. Being pressured into sexual activity with some ideas of consequence, like if you don't do this, then I'm not going to give you your promotion or I'm going to bust you down. That's what we've termed command rape, as well as the inability to consent to sexual activities, such as when intoxicated, and physically forced into participation. So it can involve things like unwanted touching, grabbing, fondling, any of those type of things, and then kind of moves up from there to oral sex, anal sex, all the way to sexual intercourse. Physical force may or may not be used. Other examples are threatening and unwelcome sexual advances, things like somebody writing very sexually suggestive emails to somebody, leaving notes for them, those kind of things that fit in kind of the harassment part, and offensive remarks about that person's body or their sexual activities. Those sort of things also fit into the category of military sexual trauma. Since 1992, the VA has been legally mandated to address military sexual trauma. That is the year when the public law first came into effect. And that there's been a variety of laws since then. There's a law in 1994, in the year 2000, and the latest was 2004. So this is the current mandates that exist to provide care for physical and mental health conditions related to military sexual trauma, to provide staff with training on military sexual trauma related issues, engage in outreach to veterans about services available, and to monitor the outreach and treatment that's going on at each facility. So what does this mean for the VA? What does this look like? What happens is all veterans who come in for care at the VA have to be screened for military sexual trauma. And if you've worked at a VA or plan to work at a VA, there's a whole screening that has to be done for everybody that comes in. And that all treatment, and that includes medications for physical and mental conditions related to the military sexual trauma, is free. There's no limit on duration for that. That can go on for years. Every facility has to have a military sexual trauma coordinator. That person at this VA is me. I'm the point person for issues related to military sexual trauma. I'm also responsible to ensure that monitoring is happening, that treatment is going on, and that education and training occur in the area of military sexual trauma. And most frequently, recently what's happened is the Office of Mental Health Services has funded a military sexual trauma support team, and they're located in Boston, to make sure that the VA meets the legal mandates. So I kind of report to them through a chain of command. And so they provide a variety of things to me and then help me and assist me to make sure we get our mandates met at this VA. They monitor all the screening and treatment across the country. And every year we get a report on how we're doing. They look at education and training that we're involved in. And then they promote the best practices nationally. So some of the new things that are happening at the VA actually kind of started in the area of military sexual trauma, some of the new rollouts for empirically supported treatments. And I would say the other thing that this team does is they provide educational materials. So a lot of the slides that we're looking at actually come from them. So to get the free care, there's only 2 requirements for eligibility for the veteran. They state that they have experienced military sexual trauma and that the provider believes that the treatment is related to their experiences of military sexual trauma. That's the only requirements for eligibility. So service connection is not required, and a specific diagnosis is also not required. There's a variety of diagnoses that go along with military sexual trauma. Many veterans can receive care even if they're not eligible under other circumstances. So for example, we have had veterans who've come in and their length of service was too short to really be available or to have VA care, except that they have experienced military sexual trauma. So they can come for that care specifically and only, and it's limited to that. Another example would be maybe somebody was discharged dishonorably, which means we can't see them at the VA, with the exception of military sexual trauma. That is the one exception. We can see them then. And at our VA, there are several that fit into those categories. The other thing, the incidents that happened in terms of the trauma do not need to have been reported at the time that they occurred. In fact, the majority of the veterans don't report. So kind of the bottom line is to not assume that somebody is going to be ineligible for care when this is what has happened to them. It's something to really double check with, especially with myself. I know I have now a lot of the eligibility folk at the VA do call me and contact me, so we kind of check it out and say, oh no, this person's okay. So that's been very helpful. I think I already covered what kind of my role is. Kind of the next level up is the VA is organized in what are called VISNs, and we're part of VISN 18. And there's a point of contact that's part of this group. So this is Arizona, part of New Mexico, and part of Texas, or all of New Mexico and part of Texas. That person is actually located in Phoenix. Covered a lot of what was on this on the military sexual trauma support team. So the next slide is how common is military sexual trauma? What's the prevalence rate? How often is this happening? So there's been several studies done that have looked at the prevalence. And so here are some of those. The Department of Defense in 2002 did a survey where they looked at a sample of the active duty folk, and they looked at did they experience any of these military sexual trauma experiences in the past year. And they divided it between men and women, and they also came up with a definition of sexual harassment versus sexual assault. So you can see on this slide that the prevalence for sexual harassment for men was 23% and assault was 1%, while for women the sexual harassment was 54%, with sexual assault being 3%. The next study was done with reservists, and this was Street in 2003. They looked at incidents of military sexual trauma that happened anytime during service. So sexual harassment for men was 27%, with 3% being sexual assault. For women, it was 60% for sexual harassment and 23% for assault. And the last study on here is from Skinner in the year 2000, looked at users of VA health care, and this occurred anytime during service. So these are folk that are already coming to the VA seeking services. And this was a national sample. They did not look at men, but they looked at women in this study. So for sexual harassment, it was 55% with 23% for assault. So kind of, at least the numbers looking at any time during service seem to be kind of comparable. This next screen comes from the screening data that comes from the military sexual trauma reminder that happens in our computer system. So this is one of the information that goes back to the military sexual trauma support team, and this is coming from their office. So they looked at all of the VA users in the fiscal year 2007, and the time frame again was anytime during service. And these are the actual numbers with the percentage. They didn't define harassment versus assault. So for men it was 1.3%, women it was 22.2%. Then they looked at, in that same data, they pulled out the OEF, OIF users. And again, it's anytime during service, not necessarily when they were deployed, and found lower numbers, 0.8% for men and 16.7% for women. So some of the thoughts about that is, you know, for the new veterans just returning, they're not necessarily quite ready maybe to come forth with this. There's some stigma involved, as you can imagine, and maybe some delays in seeking care. I don't think we've seen all of our veterans return yet.
Can you remind me what OEF means?
Operation Enduring Freedom and Operation Iraqi Freedom. OEF is Afghanistan, OIF is Iraq. These are veterans who have served in those areas. Sorry, got our VA talk that isn't always helpful. So then I pulled out kind of our rates at our VA. I don't have the percentages because what they gave me as a report is just numbers. So this is looking at fiscal year 2007 and fiscal year 2006. So you can kind of see as you look at these, the numbers are pretty comparable for men and women that are reporting military sexual trauma. And it's going up a little bit each year. So that kind of brings me to the next one about, what about military sexual trauma in men? We tend to think of sexual harassment and sexual assault as being women's issues. And while it's true that the prevalence of military sexual trauma is higher among women, so there's a higher percentage that have experienced this, the issue within the VA is that there's a disproportionate ratio of men to women. So that means that at each VA there's comparable numbers of men as well as women. This slide is looking at the military sexual trauma and how kind of virulent is it in terms of developing PTSD as a diagnosis. It is a particularly toxic stressor, meaning that it does produce greater numbers of folk who develop PTSD as a result of this trauma. So this was a study done in 1995. At this point, women were not in combat. This would be interesting to look at now that we have women in combat. But you can see in the first column of looking at rape, 45.9% of women who were raped develop PTSD, and 65% of men who are raped develop PTSD. Compare that to combat for men, which is 38.8%. So you have a significant difference in developing PTSD depending on the trauma that you've experienced. The other ones are looking at molestation and physical abuse, looking back at childhood things. And then this was a study that was done of the Persian Gulf War veterans and looking at the probability of developing PTSD. And this, they did use a cohort of women that had been in the Gulf. So they have women in combat So if you look at military sexual trauma, 5 times higher than no trauma or nothing happening to you. In men, it's 6 times higher, whereas the combat is 4 times higher. So what affects survivors' reactions? What are the things that kind of make this worse or make this so that you will develop PTSD? And there's 3 main areas: the characteristics of the experience itself, the characteristics of the individual, and then the characteristics of the environment. So some of the things that make a difference in terms of the experience, is this a single event or is this an ongoing set of events that happen over a period of time? Is this rape or is it sexual harassment? A single perpetrator or multiple perpetrators? And is the perpetrator known or unknown? Characteristics of the individual or gender, developmental level at the time of the trauma, prior trauma experiences, and available coping strategies. And the environment, the response of others at the time, were they believed or not believed? Their need to keep working or seeing the perpetrator on an ongoing basis. And then specifically the military culture. And the military culture is pretty unique. So I wanted to look at that context with that as a background. There's aspects of the military culture that really increase that sense of hopelessness, isolation, betrayal that go along with this. One of the things is when you start basic training and you're just starting out, you really get the first piece of this, the really high value on loyalty and teamwork. Everything is oriented, are you doing your job? Are you part of the team? You know, that you don't have the sense of being an individual. So loyalty and teamwork are a big deal. That makes being attacked by a fellow soldier even that more shocking and incomprehensible. How could this happen when we're supposed to be a team and you're supposed to have my back? How can I possibly trust you? This is what I have been trained and ready to do. And you hear that veterans say that in many ways as they're working through their trauma. And the other piece of this that goes along with that, it's really, you're not supposed to talk about negative information about one of your fellow team members. Just not supposed to say that. And so that kind of adds to the fact that most of our veterans don't report this. I'm not supposed to say something bad. They're a member of my team, even though this has happened to me. And there's a bunch of stuff that just starts going on in their heads and resonating. The other value in the military is really strength and self-sufficiency. You know, you have to be strong at what you do. You got to carry on, buck up, drive on, as some of our younger vets describe this. That value then makes it very hard to reach out and get social support that's available to help you cope with this. And in fact, you may get some invalidating responses because nobody else that's around you wants to hear that you might not be strong. And then being a victim really conflicts with that desired identity of being strong and being able to handle everything. And that stigma for men is particularly a problem. You'll hear some of the men describe how they're not a man anymore. I'm just, I think probably the most common word, I'm just a pussy. Nobody pays any attention to me because this happened to me. So this next slide is like looking at the setting again in terms of what we know about complex trauma. I don't know, as we're looking for the next revision of the DSM, there's likely to be a category of complex trauma in there. So this is some of the things that have been hypothesized about what that looks like. So complex traumas involve interpersonal victimization by a known perpetrator, somebody known to you. It occurs early in development. It's ongoing over a period of time, so there's multiple events. It involves prolonged terror, captivity, and helplessness. The stress is more chronic, the emotions more intense, and the meanings less resolvable. And the experience is that they're even more psychologically destructive than kind of simple traumas, which would be a single episode that happens. So let's look at that in terms of military sexual trauma. In the military, the victim typically knows the perpetrator. It's somebody who's known to them. It may be a fellow soldier, it may be one of their commanders, one of their officers. So you've got a known perpetrator. Victims are typically chronologically and developmentally young. They're 18, 19, 20 for the most part. And the risk is ongoing. So there's repeated exposure to the perpetrator. You have to continue working with this person. The victim may be dependent upon the perpetrator for basically all aspects of their life. This is kind of one of those unique things about the military is your whole well-being in the military depends on your command structure. Whether you get paid, whether you have housing, whether you have, most of your friends are going to be in the military. All of this, everything kind of centers around the military. So the risk is greater because the perpetrator may be a commander that has control over all of those aspects of your life. And the threat of death is real. What is the training that's going on in the military? The training is to be able to handle yourself in combat. Even in peacetime, that's what the training is, to be able to work with your various weapons, to be able to defend yourself. So the threat of death is real. Then if we look at previous trauma history, there's high rates of childhood trauma among veterans, especially those who experience military sexual trauma. A lot of veterans describe going into the military because they wanted to get a sense of power and control from a childhood that they felt very powerless and kind of at the whim of whoever was around. This can greatly impact how later traumas are experienced and seen for that person. So one of the pieces is that later trauma then confirms what their view of the world is. The world is dangerous, the world is bad, people are bad, can't trust people. So it's confirming what they've had happen before. And there's after effects of the earlier trauma that impair their ability to cope with the later trauma. So they don't have the social support. They may already and probably do blame themselves for what happened in their childhood. It's their fault, all of which kind of add up to the difficulty in coping with later traumas. The effect of the trauma appears to be dose specific, meaning that the more trauma you experience, the worse your outcome is, the more difficult it is to deal with, the greater likelihood that you have PTSD. And then childhood traumas are typically more complex traumas as well. If you go back to the previous slides, you can see if you're thinking of some childhood traumas, they do fit into that known perpetrator, happens over time, can't get away from it. Another factor in military sexual trauma is that it's an interpersonal trauma. It is perpetrated by another human being. It's often a close friend coworker, intimate partner. It involves a profound violation of boundaries and personal integrity. Very difficult then to set limits. And how do you know when you're safe? And how do you make sure that you're safe? Very hard to do. It sends very confusing messages about what relationships involve, what's acceptable in a relationship, what rights that they have in a relationship in dealing with others, and what is private to them versus things that are kind of publicly available. And then that has significant implications for later relationships and the understanding of themselves. And that's particularly true when you've got a young child who's being affected by a traumatic event and it's chronic and repeated. So some of the ways that trauma affects people, both physiologically, emotionally, and cognitively. So your body gets very sensitized to threat. You may even see threat where it maybe doesn't exist. Prone to have that all or none reaction, that fight or flight kicks in. Have disrupted memory and cognitive processing, hard to think things through. Emotionally, intense feelings that is very difficult to contain. I would say on the other side there's also numbing of feelings, because rather than deal with that, just numb everything out. Normal systems that promote homeostasis are overwhelmed. And again, there's that all or nothing kind of reactions, the fight or flight again. Cognitively, it definitely affects how we view the world. Have a very changed outlook towards other people and what the world is like. Really disrupts that sense of power and control, trustworthiness of others, their sense of self, and again, the fight or flight response. So some diagnoses that are associated with military sexual trauma. And the first one is the one that we all think of, post-traumatic stress disorder. That's definitely one that's associated with this. But there's also depression, complete with suicidal thoughts and or suicide attempts. Substance abuse and dependence, really as a way to numb out and not feel things. Eating disorders. A lot of people describe that really as another way that they numb out. They don't have to feel anything. Dissociation, especially if you've also had traumas when you were younger, then dissociative disorders really do follow the more trauma that you have. That's how you learn to cope with it. Borderline personality disorder, which I tend to think of as a part of complex PTSD, where it's been ongoing over time. That's a common diagnosis. And somatization disorders. Folk who probably, if they could express it, would be depressed, but instead it comes into their, and is expressed in their body. So a lot of gastrointestinal reactions are particularly true, as well as migraines. And then there's physical health problems that go along with this. It's very common to have lower back pain, headaches, pelvic pain, the GI pain and symptoms, sexual dysfunction, gynecological problems, and chronic fatigue tend to happen a lot. So what do we know about military sexual trauma and our Afghan and Iraq vets? Unfortunately, not a lot at this point. There is gathering of data that's happening nationally to look at this a little bit more and see what the rates are, where are the vets going for treatment, what's happening. Some issues to consider with the younger vets is that the trauma is recent, so the reactions are going to be acute. I know when I was doing PTSD work on the inpatient unit, we would see a lot more dissociation with the younger vets. So you kind of have it looks a little bit different. There's an interaction between the combat exposure and the military sexual trauma, but what that is, we're not sure just yet. Another thing is traumatic brain injury is probably the most common physical wound for our younger vets. And how does that affect treatment, as well as how does that affect the rates of military sexual trauma? And the issue of compounded stressors. You know, these veterans are away from home, away from their support network. Many of them are reservists and National Guard, so that really adds to another dimension here. Now, the Department of Defense has some new policies and programs. They're definitely an improvement, at least we recognize this, but they're really not tested yet. So as time goes on, we'll kind of see, did this make a difference? So one thing to keep in mind, kind of all of this being said, many vets who experience military sexual trauma do very well. They don't really have a mental health diagnosis, they don't have the physical complaints, and they cope quite well. If you look at some of the resiliency literature, you can kind of look and see why that might be. These maybe are folk who had more support, didn't have prior traumas, things like that. But for other folk who've experienced military sexual trauma, these difficulties are more severe. So as we move into the area of treatment, one of the questions that does come up is, do you need specialized training to treat military sexual survivors? Well, on one hand, no. I mean, the plain old good clinical skills really serve you well. And really having a good grounding in trauma and how that works and what the treatment is that works for trauma really helps to go a long way for treating military sexual trauma. On the other hand is the yes. There's specific things like we've looked at here in the slides about the military that make this trauma a little more difficult to deal with. And some of those issues that come up with military sexual trauma, they don't quite look the same as maybe combat trauma. In particular, I would think about relationships are much more difficult for the military sexual trauma survivors. So knowing some of that about sexual trauma is really important, and knowing the military context. You know, I hear all the time, well, why didn't somebody report that? Well, you know, given the chain of command, what the risks were, it's totally understandable why somebody is not going to report. So treatment skills. You're looking at those plain old good clinical skills. So being able to form a therapeutic alliance is important. And knowing that in the area of trauma, it's going to take longer for you to develop that alliance. Trust is one of the big factors that's affected. Demonstrating just regular cultural competence, having a systematic way that you look at case conceptualization, and then regularly monitoring your patient's progress and adjusting your practices accordingly. And the last piece is the empirically based treatment protocols. These are a wonderful new addition to maybe your toolbox that you didn't have before. It is the way that the VA is moving. We have a mandate to provide empirically based treatment nationwide, and we'll cover some of those coming up. So here are some of those empirically based treatment protocols. Seeking safety is one of those. It's a manualized approach. It really works at establishing safety and reconnecting and making meaning. It is not an exposure protocol, so you don't go through what happened to you. Along the same, well, not really along the same lines, but there's also dialectical behavioral therapy that also establishes safety and reconnects and makes meaning. A very good protocol to use with complex PTSD in particular. Cognitive processing therapy. This is an exposure protocol, and it really works to remember and mourn, and then reconnect and make meaning, and change some of those beliefs that happen as a result of the trauma. Prolonged exposure is another protocol that is also an exposure-based protocol to remember and mourn, and then to reconnect and make meaning. And the last one is acceptance and commitment therapy. And that really works probably best for reconnecting and making meaning and working on values and moving forward in your life. Some things that military sexual trauma survivors need. Practical assistance, just finding safe housing. I have many of my vets are homeless with children. And they're really working hard on boundaries, which is down at the bottom here. I've had vets who have people coming into their house unwelcomed and think they're upset, but they're not really sure how to set the boundaries. So we work very hard on setting those boundaries, and that's not okay for somebody to come into your house when you haven't asked them in. So their sense of safety is an important piece. Are they in a safe place? Sense of control. Can you do something about this if you're not? Yes, you can. Some vets really need to talk about their experiences. They really need the exposure piece. They're trying to make sense of it. I have vets who say, I don't remember all the pieces of this, but I want to talk about it so I can maybe remember all the pieces. Other vets don't want to talk about the experience. Help in managing their symptoms and regaining the stability emotionally. You know, what skills do they have to kind of self-soothe, to take care of themselves? And to know that they're not crazy. Because they have been thinking for a long time, I'm crazy, there's something wrong with me. So looking at boundaries. Boundaries tends to be a big issue that comes up maybe more with military sexual trauma than combat ever does. So this is really kind of that expected and accepted psychological and social distance between individuals. You know, we can think of that in terms of physical space, but also psychological. Survivors don't necessarily know where boundaries lie in different relationships. I've had vets say, oh, you know, I'm a really friendly person, and so when somebody comes up and starts talking to me and they want my phone number, I give it out. And I go, whoa, do you know this person? No. Should you be doing that? No. So we're relearning boundaries of where the limits are. That if you don't know this person, you don't give that out in the first time. On the other hand, you have survivors who see certain things as violations of their boundaries that are perfectly normal for a relationship. I see that's happening in my groups. I have some groups that are really boisterous and everybody, you know, they all chime in and they have something to say. And I'll have one or two members that are not comfortable with that and feel like people are avoiding them or being mean to them, and we have to work it out every single session. That's kind of where the boundaries are in the opposite way. In the healthcare setting, boundaries come up in the length and frequency of sessions, any out-of-session contact that you have, and your own self-disclosure about yourself. There may be some special accommodations that you need to make from what is your routine care when you're dealing with a sexual trauma survivor. One is honoring a request for a provider of a certain gender. I'd say don't make an assumption that if this is a female survivor, that they won't see a male provider. You got to ask them. But some will say, I'm not seeing a male. It's not going to do it. Avoiding behaviors during the clinical encounter that can be triggering. A common one might simply be shaking somebody's hand. I have several of my survivors who are not comfortable with any sort of touch at all, and get nauseous when somebody shakes their hand. Another possibility that you may have to do with somebody is doing a brief phone check-in between sessions, just to see how they're doing. Some folk really need that, like, oh gosh, I'm so glad to hear from you. Yes, I'll be there Friday for group. And then you got to consider yourself, your own personal limits and needs. You need to avoid the situation where you're overly burdened by the survivors on your caseload. It can really be very, kind of feel very overwhelming for you, very burdensome, and kind of raise your resentment. And then I guarantee if you've got a sexual trauma survivor, they're going to tell that. And they're going to feel uncomfortable, they're going to act out perhaps. So really kind of knowing that and kind of knowing that about yourself. What are your limits? There's some providers who, when they get overburdened, they just kind of distance. And too much distance is also a problem. So you got to kind of figure out what's the appropriate boundaries and limits. Looking at military sexual trauma related to other types of trauma, there's an extreme of emotions, both flooding of emotions and constriction, the outward sides of that. Self-blame is a guaranteed. It's my fault, I shouldn't have been there, I should have worn something else, I should have walked a different way. Some that are just incredible, but I guarantee it's there. Difficulties trusting themselves and others, or trusting too easily. So kind of that difficulty with, I can't really trust who you are as a therapist, maybe you mean something bad will happen to me. Strong reactions to justice and power and control dynamics. So really reacting to news stories might be something that comes up. Difficulty establishing boundaries. Difficulty being in environments that are dominated by men. That comes up quite a bit, especially at the VA. Re-victimization, self-injurious behavior, so things like cutting, suicidal thoughts. And for men in particular, some of the things that come up are homophobia, confusion about sexual identity, hypermasculinity, and hypersexuality. So some ways this shows up in therapy. A lot of our sexual trauma survivors really delay in seeking care for years. They do not come in until years after. Frequent no-shows. They'll start therapy, but then they won't come back. More need for that out-of-session contacts, maybe phone calls, boundary violations, the need for you to repeatedly prove yourself. Are you trustworthy? Are you competent? What happens a lot with our psychiatrists is, they gave me this medication and it didn't work, I'm never going back. You really need, this is a relationship with your psychiatrist, you need to go back and work this out. Nothing is good enough. Breaking and pushing the limits with the rules. We see this at the VA. I have a couple of vets I can think of who are in groups, and they every time somehow manage to get into the group room behind the locked doors on their own. And they're really pushing those limits. So they do that kind of thing. Dissociative behavior. Suicidal threats and attempts, self-injurious behavior. A lot of folk that are cutting. I have several that are pull their hair as well, and engaging in power struggles over stuff that just doesn't really make sense. Other ways, asking for but then rejecting help. Okay, I'm going to start on this therapy, but it didn't really work. But they didn't really do the homework either. And then crisis after crisis after crisis. So you never can get to the trauma itself. There's always some new crisis coming up. Oscillations, the Dr. Jekyll and Mr. Hyde. So you have folk that kind of go between the Axis 2 kind of flavor and kind of normal. And you don't know what they're going to be at any one time. Bizarre interpersonal behavior. Stuff that it's like, where did that come from? I don't know. Refusal to be seen by male clinicians. Intense anger and hostility. And then extensive physical health care issues. Seeing a lot of the medical doctors a lot, weekly sometimes. One of the areas that comes up from very frequently is that re-victimization. Folk who are not able to really set those boundaries and make sure that they're safe. And this is a really challenging issue. Domestic violence rates are higher. And that's on some of this slide looking at that. So abusive partners, unsafe sex, prostitution is a common issue that comes up. And the same person can have these really kind of poor boundaries, but then on the other hand, they live in a fortress. They're locked in tight. They have locks on all their windows and their doors. They have floodlights. And it's hard to kind of put this together. It doesn't make a whole lot of sense. So some of how this leads to re-victimization. So especially those who have childhood abuse, they really have never learned self-protection. So how to take care of themselves, how to protect themselves from others. They have a very negative self-image, so somehow feeling like they don't deserve to be safe. They don't deserve to have good things in their life. And then for some folk, they tend to dissociate in the presence of danger, which then can lead them to be more susceptible to that environment because they're not taking measures to protect themselves. So things like trusting too easily, intoxication, how that emotional flooding, then they wall off the internal experiences and they don't listen to that little voice inside that says this isn't safe. And remaining with an abuser to kind of a way to maintain hope about others and that not wanting to see themselves as a victim. See, I'm fine. So some themes that come up with men. Common themes are secrecy, not wanting to talk about this, not wanting anyone to know. We have this lovely computer system that frequently the male MST vets ask me, how much do you put in there? Who sees those notes? Where do they go? That's part of that secrecy. Gender identity concerns. Well, I'm not sure, am I heterosexual, homosexual, who am I, where do I fit? Homophobia. If I talk about this, somebody's going to hurt me. They're not going to really let me kind of explore this. Confusion over the sexual identity. Substance abuse. A big one to really, that's kind of the acceptable way to deal with things is just use a substance and then you don't have to feel anything. Difficulties engaging in therapy. Physical symptoms, we've talked about a few of these. Sexually transmitted diseases, chronic pain, GI disorders, gynecological disorders, dissociative memory loss, and then some non-specific immune system disorders. Chronic fatigue syndrome, lupus, fibromyalgia tend to run higher with military sexual trauma. So, on to the last leg. What do we offer at the VA? Here's a sampling of what we have to offer for treatment. I do a trauma education group series, which I'll explain more on the next slides. We also have seeking safety for both men and women. We have dialectical behavioral therapy, again for men and women. A mindfulness group, and then we have an acceptance and commitment therapy group. So let me explain a little bit more about what I do. This is another MST specific group. This is how treatment goes that I conduct. So I form a group. The members begin the group together and they proceed through each subsequent group as a cohort. So they stay together. They really get to know each other. This is really important for trust. And especially as we get into some of the exposure work, they really need to depend on each other, not just me. That group is held at the same date and time throughout the whole series. So it makes it easier for my vets. I have a lot of vets who work, are raising small children. They have to have a consistent time to come in. Now this model is adapted from Diane Castillo's model that she has used and came up with from Albuquerque. So it all begins with a trauma education group. This is a 12-week psychoeducational group. Included in that is an introduction to relaxation and mindfulness. The next group is a skills building group. It runs from 12 to 16 weeks. We really work very hard on communication, assertiveness, boundaries, setting limits, and we go more deeper into relaxation skills. The next group is a cognitive processing group. I don't know if many of you have been exposed to cognitive processing therapy, but for those of you who know, this is a cognitive processing therapy cognitive group. We don't do the trauma story in this. This runs 12 to 16 weeks. It's a manualized treatment. The exposure group comes after that. This is an optional group. Not every vet is going to want to do this. It's 12 weeks long. It's a written format of exposure. So, the first week, come back next week, I want you to have written what happened to you in detail. And each week we add more pieces to that, but they keep rewriting their story. And that's a smaller group of veterans. Usually break out a little tiny group because you can't get through those stories in a big group. After this is a sexual functioning group. Kind of from this point on, we're kind of moving out into regaining some skills and getting ready to be out in the community. This runs for 12 weeks, using one of these two formats, Becoming Orgasmic for Women or The New Male Sexuality for Men, to really regain that quality of life. And the last group is an acceptance and commitment therapy group. This runs for 10 weeks. The focus in this group is really on reconnecting with your values and then doing activities that fit with those values. This is a kind of a forward-looking group. It's the now, what do you do with your life? What are the things that are important? How do you now live a life that's worth living? And that's the end. These are the folk that are back at the Military Sexual Trauma Support Group who really developed a lot of the slides for me. That's Margaret Bell and Jennifer Alvarez. And then that's it.